Welcome to Brain Wellness, the podcast. I'm your host, Mandi NP. Each episode will bring you a new topic or interview related to brain health and wellness as part of my mission to help you on the path to a healthier, happier brain. So, let's get started. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. Today, I am back with another one of the letters of the ABCs of concussion. We're going to be covering letter F today. So if you've been following along on this series, I do this because multiple reasons. One, not everybody knows what all the symptoms or troubles are that are related to somebody having a concussion or a traumatic brain injury. And sometimes people have symptoms and they don't know where it came from. I will tell you on a regular basis as I'm seeing my patients, we will talk about whether or not they had previous head injuries. That's always a question on my consultation. Do you have a history of previous head injuries? And sometimes they say no. And then I do some education and I remind them that you don't have to hit your head to get a concussion and you don't have to lose consciousness. And actually, by all definitions, 90% of traumatic brain injuries are mild traumatic brain injury. That term mild that we have currently, mild traumatic brain injury does not have loss of consciousness. So by definition, 90% of brain injuries are not going to have loss of consciousness. So a lot of times people kind of forget that you don't have to have that loss of consciousness to have a brain injury, and you don't have to hit your head. It can just be the momentum from your head, your brain moving around inside of your head. So when I give that information, sometimes those answers change a little bit and people say, well, yeah, I had such and such event where I was in a car accident. I had whiplash. Did you have any headache or dizziness afterwards? Well, yeah, but I didn't think about it. Nobody told me I had a brain injury. Yep. So this is where it leads to these conversations that we're having in the ABCs of concussion, because sometimes people don't know where those symptoms came from. And then you can look back and say, well, before my symptoms started, was there anything that happened that may have been an injury where I could have had my brain jostle around inside of my skull? That's a good thing to think about. And then again, if you've had a concussion or you know someone who's had a concussion, whether you're the provider, the caregiver, the person that had the head injury themselves, some of these symptoms might ring true for what you've been experiencing. And maybe you have or haven't had some treatment related to it. And I've got some ideas for you on things that can be done. So again, for the other providers listening, this is great information to know for helping your patients so that we make sure that we address our patients' concerns, make sure that we give them the supports that they need so that they can get better. And again, for the person with the brain injury or the caregiver loved one, know that these are things that you can help advocate for your loved one or for yourself as well. Without further ado, into our letters for today. So again, letter F. So everything today is going to start with a letter in addition to me, Mandi. So here we go. First one is migraine. And migraine, people have heard this term. They know this term. It's a common finding. It is one of many types of headache that we can see after a concussion or a head injury. It's not the only type. Some people kind of jump on that and think of any headache that happens after a brain injury must be a migraine, and that's not really the case. Migraine has classic definitions, and does every person's headache match this classic definition of migraine? No, but then again, there are other options that can be confused with that as well. So thinking about somebody that had a history of migraine, people that have a history of migraine prior to having their head injury tend to have more likelihood of having a prolonged recovery, unfortunately. It is not an independent thing to say, if you have this, then you will have this, but there is a correlation, and we can see that people tend to have a longer recovery time if they had a history of migraine, especially migraine with aura, meaning you had that kind of visual sensation or something else prior to the headache kicking in. That have those migraines prior to their head injury will have worsening of their symptoms. They'll have more migraines after their head injury. Some have improvement. I had migraines prior to my head injury, and I can tell you in 2.5 years, I've not had a migraine since. I have a different type of headache now, but it's nothing like the migraines that I used to have. So we can see either. We can see an expansion, a worsening exacerbation of those migraines, or we can see them improve or go away and be potentially replaced by a different kind of headache syndrome afterwards. The characteristics of the migraine can also change. So whereas we usually say migraines, especially that happen in women, can change over time. Once you've gone through menopause or perimenopause, you can have a change in your type of migraines. That hormonal change can cause a change in the characteristics of the migraine. Sometimes people start having complicated migraines or complex migraines that have neurological symptoms with them rather than just being head pain. And sometimes people have migraines that don't involve pain. So we term that an acephalgic migraine, meaning there's no head pain, but the migraine still happens. So sometimes people still have the neurological symptoms, but they don't have the headache that goes along with it. So that kind of muddies up the water a bit too. But those characteristics can change a lot of time because of hormonal changes. And hormonal changes in women, yes, we see it during menopause, but we also see it in men and women during brain injury recovery. So we can see those migraines look a little bit different. There are similar presentations between a post-traumatic headache or post-concussive headache, as I like to call it, or migraines. So they can have very, very similar findings for some of that. As far as the headache itself, the characteristics of the headache might be a little bit different. Most often with migraine, it's a throbbing sensation. Sometimes with a post-traumatic headache, you get the throbbing sensation. But generally, if there's any other sensation other than throbbing, it's probably not a migraine. But the other things that can overlap would be light sensitivity, sound sensitivity, nausea with or without vomiting. Those can happen with a migraine. Those can also happen just because of the head injury. So that's where sometimes providers kind of fall into this trap of calling all headaches migraines after a head injury, because you have those sensitivities to light and sound, you have the nausea and vomiting. But again, not all of that is just specific to migraine. We get a lot of that overlap. There was one study that I found as I was researching for today's recording on this, is that 35% of all patients with TBI continued to have chronic headaches 5 years after their injury. So this is kind of a bummer for my patients that come in and they ask me, how long are my headaches going to last? And I don't have a good answer for you, because it can last forever. And for some, it's just weeks to months. So there's quite a range of time frames in there. So it's really not a good question that I can have an exact answer for. I do not have a crystal ball. I do not have a magic wand. I wish I had both of those. It would make my life so much easier, my patient's life so much easier, but I have neither of those. So all I have for you are statistics from research that may or may not be 100% good. So we do know that about a third of all those patients that have TBI continue to have headaches when they are asked again at 5 years after their injury. Most often, as I mentioned, providers treat these headaches as migraines, as they do have some of those same overlapping symptoms, but it's very unclear in the research whether or not these treatments really benefit the patients. So there's really a wide variety of responses, whether or not they help or not help, and the post-traumatic headache in general has not really been studied as extensively as migraine because people are more familiar, they know how to characterize it, so there's not a lot of certainty in the research. I can tell you from my own personal experience and from experiences with most of my patients that traditional migraine treatments do not work very well for post-traumatic headaches, my own personal experience as well as my patients. So we usually have to treat things in a different way. Management of migraines, then, when we're specifically focusing on these migraines, because yes, patients can have migraines after head injury. If we're looking just at that, there are some lifestyle management things. And these lifestyle management techniques kind of make me giggle a little bit because it's really things that we all should be doing anyway. They are the simple but not easy things to do. So drinking plenty of water. Again, I've mentioned this in multiple different episodes regarding multiple different things on this show, but drinking plenty of water means in general that you're drinking about half your body weight in ounces of water. That's at baseline. So take your pounds, divide it by 2. So if you weigh 200 pounds, half of that is 100 ounces of water that you should be drinking at baseline. If you do any kind of exercise and you sweat, you should increase that. If you drink caffeine, whether it's coffee or soda, you should increase your water intake. So I usually say for every cup of coffee or every can of soda you have, you should have a glass of water to offset the dehydration that comes from the caffeine as well. So lots of reasons why you should increase that water intake. Getting adequate sleep. And this is a difficult thing for anybody with a brain injury to do because often your sleep is affected as well. But it's really, really important to get adequate sleep for any kind of headache with or without a head injury to try to minimize the recurrence of those headaches, to try to minimize the severity. And adequate sleep will depend on what age you are, because there are categories online where you can look up little calculators to see how much sleep should you get for different age categories. Children need a different amount of sleep than adults do, and adults need different amount of sleep depending on what age they are as well. So getting adequate rest, adequate sleep based on your age and based on whatever else is going on in your health history, honestly. And then making sure that you get enough protein and eating a healthy diet. Healthy diet might look different from one person to the next. In general, I usually say eat the rainbow, eat lots of different kinds of foods, because all those different foods and fruits and vegetables of different colors have different vitamins and nutrients in them. It's really important that we get all of those. But protein is especially important as well, because protein can help decrease headaches, again, with or without a brain injury. So making sure you have enough is really important. Again, there are calculators online that can help you figure out, based on your activity level, your age, your gender, all of these different things, taking into account where you are with your menstrual cycles on some of them, how much protein that you need. Making sure that you get enough protein will also help to try to reduce some of those headache days. And then exercise is really, really important. Maybe not exercise at the moment that you have the migraine, because I've tried doing that before. It does not work very well. But getting in some regular exercise also will reduce your frequency of headaches and migraines in general. Walking is great. So for many, many years, we've always thought that you have to do these really high intensity workouts to get a good cardiovascular workout. And there's a lot of research coming out now showing that walking is fantastic. So I tell this to my patients all the time. If you do nothing else, walk. Just get out walking. There are a lot of apps now that you can pay for that tell you how many steps you need to get in a day. Basically, more steps than you're doing right now is probably a good place to start. So walking is fantastic. Stress management, again, this is another one that is easier said than done. And a lot of people will say, yeah, sure, manage my stress when I'm not working. I can't get back to my normal activities and XYZ, all these different reasons after a brain injury why you might have stress. So stress management is really important. More than just a concept, something that you actually should do to try to minimize headaches, because stress can be a trigger for lots of headaches, again, with or without a brain injury. And then avoiding alcohol. Alcohol and brain injury are not good friends to begin with, but if you have headaches of any kind, migraines included, trying to avoid that alcohol will also be a benefit to try to reduce the frequency and severity of those migraines. There are a lot of supplements that we can kind of go to, and I'm a supplement gal. Patients come to see me. That's the first thing that I jump to, is looking at natural ways that we can supplement the things that you're normally supposed to have in your diet anyway, that we don't always get because we don't have great diet. And sometimes we have deficiencies, such as vitamin D. I live in Minnesota. Pretty much everyone in Minnesota is deficient in vitamin D. If I were to check 100% of my patients that come in, probably 100% of them will be deficient unless they're taking a good amount of vitamin D to begin with. But some of the supplements that we can use in clinic include vitamin B2, which is riboflavin, vitamin D, magnesium. Magnesium glycinate is my favorite. There's a lot of research to show that that one is the best for reducing headaches and improving sleep. I saw a good table recently that kind of compared all the different ideal uses for the different forms of magnesium, and the glycinate was the number one there for sleep and headache. So that's my go-to. Other supplements can include fish oil, curcumin, or turmeric, or whatever version of it that you take. Turmeric is the cooking spice. Curcumin and turmeric both can be used as a supplement. It's not a great flavor, so I like the capsule version of it, so you don't have to take a big old spoonful of that turmeric on a daily basis. CoQ10 is another good one that we talk about, and then creatine. So I did an episode with the founder of Concrete Creatine. If you want to look back on that episode, that we did a whole conversation on it. But all of these are ones that I will talk to my patients about and see if they would benefit my patients in different categories. So if you are the provider or the patient, all of those would be ones that you could potentially look at for reducing headaches of any kind, but also migraines more specifically after a brain injury. So those are ones commonly talked about. Other treatments that we can consider include physical therapy. There's a lot of neck issues that come along with a head injury. Neck issues lead to a lot of headaches and migraines. So again, trying to deal with that neck pain is a really important part of that. Physical therapy, massage, acupuncture, all of those can work. Biofeedback, dry needling is another one. And then we can get into like the more prescription type or over-the-counter medications aside from the supplements. So initially when we're looking at things like NSAIDs, ibuprofen, acetaminophen, Excedrin is a really good kind of first go-to. Excedrin is a combination of acetaminophen and aspirin and caffeine, which again, sometimes we talk about, is caffeine good for your brain? And there are conflicting information. Sometimes caffeine can be helpful for headaches. Sometimes caffeine can be a trigger. So for some of these, Excedrin can be a great choice in addition to ibuprofen, acetaminophen. The downfall that I see there is that a lot of providers, especially in the acute phase from the emergency room, from primary care, they'll say, yep, go ahead and trade off the acetaminophen and ibuprofen every 4 to 6 hours, whatever. But they don't put a time frame on there. And then months later, I'll get the patient to me in clinic and they're still doing this ibuprofen, acetaminophen every few hours because they were told to do it and never told when to stop. And then we can run into the risk of rebound headaches or medication overuse headaches because we've been doing all of these things and you essentially kind of put your body into withdrawal when you try to take them away, and you will end up with the headache because then you try not to take the ibuprofen and acetaminophen. So maybe for the first few days. Beyond that, I would not recommend continuing that because even if you use ibuprofen or acetaminophen or Excedrin more than a couple times a week, that puts you at increased risk of having that rebound headache or that medication overuse headache. If we are thinking it's a migraine, the triptan medications, rizatriptan, sumatriptan, any of those, they go by the brand names Imitrex, Maxalt, Relpax, all of those can treat that headache at the moment. They're abortive therapies, meaning they stop that migraine from happening. Those are what we use without a brain injury, but if you have a brain injury and you have a migraine, those triptans can be helpful. So that's when I have that conversation with patients when we're talking about kind of that overlap between the migraine and the post-trip headache. If they're taking their triptans and it's not relieving their headaches, it's likely not a migraine. That's when we're looking at that probable post-traumatic headache because they typically don't respond to the same kind of treatments. They don't like those triptans. They don't respond. That was my experience. That's a lot of my patients' experience is that those triptans just don't work. And that's probably why, because those particular headaches are not actual migraines. If we look at somebody that's got headaches all the time, day in, day out, and we've tried the supplements, we tried to clean up their sleep as much as possible, but they're still having daily headaches that really impact their lives, that's when a daily preventive medication, that those prescription medications can come in handy. There are many different medications that fall into this. Typically with migraine, there are 3 different classes that we start with. The beta blockers, so blood pressure medication, anti-seizure medications, and antidepressants. There are a few in each of those classes that we can look at. There are newer medications like the brand name Qulipta, other treatments that we can do, and there are some injectables as well for prevention that we can use for those patients that have those headaches that just continuously go on and on and on, because it's pretty miserable if you've got migraines all the time. And then if you have more than 15 headache days in a month that are not treated well with any other treatment, that's when patients would potentially qualify for Botox injections. But Botox can be beneficial for the person that has these significant migraine headaches after a brain injury. Again, not all headaches after brain injury are migraines, so that's that thing to keep it into count on this one when you're trying to figure out if medications are going to work with your patients or not. If it is that post-traumatic headache, we'll talk about that more in the P letter. I'll probably bring that back up again. We did talk about it back in H with headaches. But if it's that post-traumatic headache, we really should be looking at what's going on in the brain that we need to treat underlying this, such as visual issues, auditory issues. Are there autonomic system upsets that we need to deal with that can be leading to more of these post-traumatic headaches, whereas we might not need those prescription medications. We might need to fix those underlying problems, and then the headaches will reduce. Migraines, if we're dealing with those, again, stress, sleep, hydration, nutrition, those things in general, with or without a headache, are very important for lifestyle modification, and those can help reduce the need for a lot of those prescription medications as well. Will it eliminate them? Possibly not, but it definitely will reduce the need. Next topic is memory. And this one is something that probably all of my head injury patients experience at some point. It's probably one of the biggest concerns that people come in with when they come to see me. Most often we're seeing short-term memory loss. We have short-term memory, we have long-term memory. The short-term memory loss is the one that's usually more affected than long-term. What does it look like if somebody has short-term memory loss? I think we all kind of have an idea in our head, but it can look like multiple different things. It can be forgetting important details in a conversation. That can look like you're not paying attention, but it can just be that you didn't remember it being said in the conversations. Forgetting those important details in a conversation, forgetting where you left things, putting your keys down, putting your phone down, your purse, whatever, setting something down and not remembering where you put it. It can be feeling unsure of what you did earlier today, what you did yesterday, last week, etc., not remembering what you did all of these different times. That can lead to you repeating things. So you can't remember if you talk to somebody about something. So you might tell them again, or you might ask multiple questions because you don't remember. Conversation happened, something happened, but you don't remember it happening. So it leads to you asking questions or repeating yourself. A memory loss, in this case, short-term memory loss, can look like losing track of time or forgetting what day it is because you don't remember things from one day to the next anymore, especially if you're not at work. Sometimes when you're at work, you have these routines that you get in because things happen on a certain day at work. Mondays, we have this meeting. Tuesdays, we have this meeting or whatever that looks like. And then when you're not going to work because your brain is injured, it's difficult to keep track of those days to begin with. But also just losing track of time in general. You go to do something and it takes you longer than you expect. Next thing you know, you look at the clock and an hour has gone by when you anticipated it would just be a quick little project. Short-term memory loss can also look like being able or unable to retrace a route that you took earlier in the week. Maybe you have physical therapy now a couple times a week, and you have to go to the clinic down the road. You went there, you followed your map to get there that first day. Second day, you have to go. You can't remember how to get there. You got to pull that map up again because you cannot remember how to get there. Maybe you put something down earlier in the week and you kind of think of what you were doing, but you can't quite retrace your steps to figure out where you put it. All of that would be that same category. It can be forgetting all or part of a movie you watched or a story that you read. I can tell you, in the last 2.5 years, I have watched several movies with my family that I don't even remember watching. So this can be a big, big thing where you don't remember the entire movie. And maybe it was something you went to a theater or you watched it at home. Maybe you can remember parts of it, but not all of it. Or a story you read, whether it's a news story or trying to read a book or something like that, just not remembering everything about that story. Short-term memory can look like forgetting to keep appointments. You have appointments, you put them on your calendar, but maybe you didn't set a reminder for them, and therefore they don't happen because you can't remember that there was even an appointment that was put on your calendar. And if it didn't remind you, you don't remember. And then saying that you'll call somebody or visit them and forgetting to do so. So you get off the phone and something happens at home. You say, hey, I got to get off the phone. I'll call you back in a little bit. Never call them back. Or somebody calls you, you're at the grocery store trying to remember the few things that are on that grocery list. Hey, I'm at the grocery store. I'll call you back. Forgetting to call back. Meeting up with somebody saying, hey, we're going to have lunch on this date. You don't remember to have lunch on that date, or bringing something for a potluck at work. Don't remember to do that. So all of those can be that short-term memory as well. It just didn't get ingrained there. And then forgetting what you went into a room to do. I remember years ago reading about this. There's actually a phenomenon that if you walk through a door, you can forget things. So even without a brain injury, this is something that people can forget, but forgetting why you walked in a room. Maybe you meant to go get the TV remote that you set down on the kitchen counter when you walked out to the kitchen last time. You walk out to the kitchen to grab that TV remote. You get out there, you look around, and you cannot remember for the life of you what brought you into the kitchen. You don't remember the remote. You go back out to the living room to watch the TV. Remote's not there. Oh yeah, that's what I was going back in the other room for. And you can have this happen a couple times by the time you really can't remember what you went in that other room for. Forgetting to pick people up at a certain time. Maybe a friend of yours or family member is going to the airport. They're flying out somewhere, coming in at a certain time. You're going to pick them up. Or you have kids at school that you have to go pick up for activities and you forget what time you're supposed to be there, or you forget completely that you're supposed to be there until you get a phone call. Hey, are you coming to pick me up? That might be your reminder. So any of those could be part of that forgetfulness, that memory loss. And then the last part is forgetting procedural activities. Not the last part. There's a lot more things that can happen, but the last one I have in my notes here, at least to talk about, is forgetting procedural activities. And this is things like forgetting how to do something. And you can literally forget how to wash the dishes, how to cook something with your food, how to drive to work. I had a patient or someone tell me that after their head injury, they were driving to work and they had to stop and pull over because they couldn't remember how to get to work. I forgot a lot of medical knowledge. It just wasn't there after my injury. So forgetting how to do things was a big issue right away after my injury. And it took some reminding myself on how to do things to get back to my normal functions. So all of those can be there. Long-term memory, it's not as common, but it can happen as well. You might recognize somebody that you see, but not remember their name, for example. Maybe it'll come back to you later, but you know you've met them, you know that you have done something with them, but you can't remember why. This can happen to people in general if they're not great with names, faces, whatever the case may be, but after a brain injury, that can be part of that long-term memory as well. I forgot a lot of things that happened even the year prior to my accident, things that were really kind of disheartening once I remembered that I'd forgotten them. So it came up again, and sometimes you don't think you're going to forget the big things, but I had friends who were diagnosed with cancer that I had completely forgotten that they had gotten diagnosed with cancer, and they were big things, but they were in that year prior to my accident. And those things didn't necessarily stay. So long-term memory can be affected. It's just not as common as the short-term things. And then there's this period that we call post-traumatic amnesia. There's a period of time after the injury that the individual cannot remember. So not being able to remember events or form new memories afterwards. Sometimes it's a matter of days, a matter of weeks. I've had several patients come in and they don't remember anything from while they were in the rehab facility. They don't remember anything until they got out, they got back home. That's when they started forming new memories again. So that's that post-traumatic amnesia, where that period of time after the injury, you have difficulty forming new memories for them to even stick into your brain. How do we manage all of these things? It seems like a really daunting task to figure out how we're going to deal with this loss of memory. Number one is sleep. I will say this a few times today, but sleep is really important for your brain, for your healing. We talked about it with migraines, but I'm sure we'll talk about it again. I can't remember what all I have in my notes for today, but I'm sure we'll talk about it again because sleep is really, really important. So making sure that you're getting good sleep so that you can remember things. And for this example, I always remind people, if you've ever watched the movie Inside Out. So the movie Inside Out, all of these little characters identify the different parts of your brain, the different emotions. At the end of the day, all of these marbles have been coming into your brain and they pull a lever and all those marbles get filed. That's what happens while you're sleeping, truly. It's a really good depiction of it because things go into short-term memory, long-term memory. Some things get discarded if they're deemed not important. But you need to sleep so that you can get into that good REM sleep where you create those long-term memories. Things get filed, toxins get filed out of your brain. So things get filed in and out in appropriate ways to help you recover and help you heal. So sleep is really important for all of that. Cognitive rehab. This is done with a speech-language pathologist or speech therapy for short on that one. Speech therapy works on that cognitive function. And I have patients all the time will talk about speech therapy and they're like, well, what is it going to do for me? I don't have problems speaking. Language, speech-language pathology. The whole pathology about why you're having difficulties with language and memory. Memory is part of that. You have to be able to remember things in order to recall things, in order to speak fluent. So cognitive rehab is very, very important to help you learn how to remember things again. And then emotional support, again, very important because if you're stressed, those memory issues are going to be worse. So trying to get some emotional support in there, decreasing stress through stress management techniques. And there are lots of little tips and tricks. And when we're talking about this, I always like to say during this point in my appointments with patients that our brain heals by two different primary means. Is the cells that were damaged wake back up, they take on their normal job. The other way is that you learn to compensate. So your other brain areas take over for the area that was damaged. You learn new ways to do things so that you can still be successful. It just might not look exactly like it did before your injury. So some of the tips and tricks that I can provide on this one, write things down. Write it down wherever you possibly can write it. My dad carries a little notebook with him. He's not had a brain injury. Well, maybe not recently, but he carries this little notebook that he writes everything down. So in his pocket at all times is one of those little mini notebooks. And that's really, really important for some people, that physical note part of it. Write things down on your phone, write it down on some sort of device. I have a remarkable tablet that this thing is truly remarkable. It looks like a normal notebook. It feels like it when I'm writing on it, but everything is electronic. And I write everything on there. My husband got me that probably 6 months or so after my injury. He had one. He used it at work all the time, and that became my new go-to because I would lose my notebooks. I had multiple different notebooks going, and I couldn't really contain any of them very well. So I would have information that I couldn't remember and I couldn't find where I wrote things down. Now, I don't have a problem with losing that because that little gadget goes everywhere with me. It's in my purse at all times. It goes to all of my appointments. At work, I use it for writing down things all the time. Meetings that I have when I meet with new people to put on the podcast, my notes of those conversations go in there. Everything is in that notebook, and it's all kept really well organized because I can tag things, I can label it. I could probably do a whole little commercial for them, but I'm not getting paid by it. So there we go. But that remarkable notebook is truly remarkable. It's been a lifesaver for me. Keeping a calendar, whether it's electronic or paper form, keeping the calendar and then looking at the calendar. So one of the things one of my therapists had me doing was every night I would look at my calendar for the next day to remind myself what all activities I had that next day, because it helped to solidify it in my brain that I had something to do the next day. I had to learn the hard way that if something went on my calendar, I had to set an alarm for it, because if there was no alarm, just putting it on my calendar did not remind myself that I had it. I had to have that alarm, and I had to be looking at my calendar. So keeping things updated, keeping things organized on my calendar so that I could be reminded that I had to do things. I've had patients tell me that as well. They had to put their alarms on it. The alarms don't happen automatically. You have to set them, but yes. Using lists. I personally have always been a list person. So when I have projects to do around my house, when it's chore day, we have lists and we can check boxes off. And I love checking off boxes because it makes me feel productive that I've done something. But using lists is very helpful if you can't remember things, because you can put it down on your list. And as long as you remember to put it on the list, chances are you're probably going to remember to do it. Sometimes I'll get up in the middle of the night and I think, oh, shoot, there was this thing that I was supposed to do. I will set myself a reminder on my phone, because then I can fall back to sleep and I don't have to worry about forgetting it because it's right there. So that's a really important thing to do too. Write it down when you think of it. Don't wait to write it down when you can't think of it. Therefore, if you're in the car and you're driving, no, I don't want you taking out a piece of paper and writing something down. Send yourself a voice note. Send yourself a text. You can do that if you didn't know that, but you can do that on your phone. You can have your phone send you a text message and remind you to do something. So there's that. I have had several people too, they'll say they'll text their partner something, because their partner then just knows that if I get a text that says, this is my reminder to do something, then they don't pay attention to it, but it's there on the phone. So that's a good one as well. When you are trying to remember things, especially that procedural part of things, break up more complex tasks into something smaller, something that you can remember. So do a little bits at a time. So do part of it, and then maybe you need to go back and review something else. But sometimes if you're trying to do one big complex task, your brain can get up and walk out of the room and you can forget how to do those things. So break up those complex tasks into something smaller so that you can remember all the different steps. It's kind of like when you're putting together a desk, for example. I bought myself a new desk. Putting together this desk, I had to follow it step by step. If you break up those tasks into smaller little pieces, it's easier to remember to do all those different steps. And then another thing that my therapist had to remind me to do over and over and over again was take breaks before you need them. If you're not taking the breaks, if you're just trying to push yourself through and get all the things done that you want to get done, your brain will run out of energy. You'll run out of juice. You won't be able to continue to do all the things that it is you want to do. So take breaks before you need them, and that will help you get through those events a little bit easier. And try not to do too many things at the same time. That also is going to be difficult for your brain as you're trying to remember all of these different things. Multitasking is not good for a brain that's injured. One thing at a time. Even trying to remember conversations with my kids. If I were to ask my kids about their school day, about something that needs to be done for school, I learned that I had to put down whatever else that it was that I was doing. I couldn't wash the dishes and have a conversation at the same time. I couldn't cook and have a conversation at the same time because I wanted to be able to remember the things that my kids were telling me. So when they're telling me about their school day, telling me about their assignments, whatever, I needed to pay attention to that so that I could remember it. Because when you're trying to multitask, you're not doing any one of those things really well. And then basically all of these things are finding workarounds. So again, that whole idea of finding new ways to do things that you used to do, different way to do it successfully. You need to find those workarounds. What's going to help you to compensate for that area that you're not doing quite as well as you did before? Those workarounds will help you to be successful. They might need to be new things that just build into your routine. That's your new thing that you do, but it helps you to function at the same level that you did before, at least. Kind of along the lines of that is mood, the next M letter. Mood can be affected by your memory. So that's why those two can go hand in hand. And it is very common to have mood changes and emotional disturbances after a brain injury, regardless of the severity of the brain injury itself. These can range from mild to severe, and they can persist for some people for weeks or months or longer. So this is another one of those things where I can't really give people a good answer to how long it's going to last, because sometimes it's short-lived and sometimes it becomes a more persistent thing. I don't like to say permanent, but it can be in some cases. So those common mood changes that we can see can include just irritability, anxiety, depression, emotional lability, meaning you can go from happy to sad in about 2 seconds flat or 0.5 seconds flat, just really fast, going from one emotion to another. And then people often will describe it to me as they have a short fuse. They're easy to anger. They just get irritated by everything really easily, and things that didn't irritate them before now irritate them. I drive my husband bonkers with this because he chews his ice, and apparently it never bothered me before, but it sure does now. So that is a very common thing where people get irritated by sounds and other activities in their life that they did not get irritated by previously. Why do we see all these mood changes? Again, there are several reasons. It can be from damage to the brain cells and the neurotransmitters. All of those neurotransmitters affect hormones in the brain, which affects our chemistry. So sometimes changes in the brain chemistry, such as hormonal imbalances, changes again in those neurotransmitters, can affect our mood and our stability with our mood. Sleep disturbance. Yep, there's that sleep word again. If you're not getting good sleep, you're going to be a little bit more irritable than you would if you had good sleep. And that usually is true for people with or without a brain injury as well. So if you're not sleeping well, your mood's going to be affected, just like your memory and your migraines and blah, blah, blah. All the things can be affected by sleep. Stress and anxiety. Again, this one comes up all the time too, because after a head injury, there's a lot of stress. And the more stress you have, the more troubles you're going to have with your mood. I remember at one point dealing with my therapist and everything, because I had some mood changes as well. One of the questions came up was whether my depressive symptoms were causing problems with my concussion symptoms. And I got so upset. I said, you know what? No, I'm upset because I can't get back to work because I still have these symptoms. That's why I have feelings of depression at all, is because I couldn't get back to work. So once we kind of got past that part, we could deal with the symptoms that I was experiencing and not try to blame it on my mood. So I have that same conversation with my patients all the time, and we try not to blame it on the mood, because it's like, which came first, the chicken or the egg? You're going to have mood issues if you can't get back to your normal activities. So those two definitely go hand in hand, and you can't assume that the mood is the cause for everything, because your mood is affected by all of those other things as well. And then again, your mood issues can develop or worsen due to frustration with not getting better, as I just stated. And if you're not getting better, it's going to cause issues with your mood. It's going to cause issues with stress, which is going to cause issues with your mood. And then you get in this downward spiral. How do we manage these? Again, lots of different ways, because sleep disturbance can be a problem. Getting rest, getting sleep, as we just talked about. Cognitive behavioral therapy. So mental health therapy is very important for any any kind of mood disturbance with or without a brain injury. But when you're talking about brain injury mental health, it's really important to work with a therapist who understands brain injury, has experience with brain injury. So I always tell my patients, call around, try to see if you can find somebody who has that experience, because they're probably going to be a little bit better for you than others. And then sometimes we do need medications for a short period of time or longer, antidepressants, anti-anxiety medications. I'm not a big medication person, but sometimes they have their place. Anti-anxiety, antidepressant medications can be useful, even if it's just for a few months, to get you through the kind of big bulk of your recovery and then kind of move forward from there. Support groups can be really helpful for mood changes after a head injury as well. Support groups allow you to talk to other people who've had the same kind of frustrations, the same kind of mood issues potentially, so that you can learn from others how to deal with those things. And a lot of different support groups will have presenters, speakers come in to talk about different things and help you through some of those different struggles. And then again, lifestyle modifications, regular exercise. Exercise is the most underutilized antidepressant out there. So exercise can definitely help stabilize your mood, especially if you were an exercise person before your injury and now you can't do that exercise. That's going to affect your mood as well. So getting back into some regular exercise will help to calm those mood issues again too. Sleep hygiene, again, it's coming back up again here. Stress reduction, which again includes exercise, meditation, yoga, mindfulness, any of those things that can help to calm your mood as well. And then give yourself some grace. So this is something that we're not always really good at, but give yourself some grace. You're bound to have a little bit more irritability. You're bound to have a lot of these issues that come along with brain injury. You need to give yourself some healing time. So don't beat yourself up if you lose your patience with something. Turn around, apologize, move forward. I had to do that over and over again for quite a bit of time, when I would snap at my family members and then have to go back around and apologize to everybody after I cried myself because I got upset with myself for snapping at everybody, because that wasn't me. So give yourself some grace. It will not always be like it is today. And that's one thing that I can typically promise my patients, is it's not always going to be like this. Things will improve. Can't guarantee how quickly or how much they will improve, but they will improve based on different treatments that you do. Kind of along that line, one of the things that can be forgotten, but something that is an M all on its own, is medications. So we've talked about different medications to treat migraines, to treat your mood, to treat all of the other things that go along with head injury. And medications can come with errors when we have memory issues. So that whole conversation about forgetting to do things, forgetting if we did things, forgetting when to do things, that can affect your medications, which can have an impact on multiple different areas in your life. You may forget whether you already took your medications. So one thing I always recommend people do is use a pill box. Use some sort of visual reminder that you can see. Monday a.m., did I take my pills? Make sure you're taking it out of the correct box, for one. But Monday a.m., did I take my pills? Monday p.m., did I take my pills? And having them organized in that box is a good visual cue for you to remember whether or not you've taken them. If you're not doing that, if you're just taking them out of the bottles individually, it's going to be a lot harder to assess, did I take my pills already? So if you have them in that med box, it's easier to look and visually see, did I already take them for today? So you might forget whether you took them already. You might forget to take them. So maybe you have them in the pill box and you just don't remember to look at that pill box. And then sometimes you might forget that you need to take them all together. So maybe you have a prescription, the prescription ran out, you forgot to refill it, you tossed that prescription bottle in the garbage, and you completely forgot that you even had a medication you were supposed to take. It has happened. It can happen. So all of those things can lead to medication errors. And what do I mean by a medication error? It can be either forgetting a pill, so missing that medication, or forgetting that you already took it and taking it again. And now you potentially overdosed on a medication. Sometimes overdosing isn't as severe as it sounds, but some of those medications, you might not want to take a high dose, especially if you're taking like a stimulant, for example. If you now have symptoms of ADHD and you're on a stimulant like Ritalin or a methylphenidate, when you're taking those, you don't accidentally want to take a higher dose or take it later in the day, because that might make issues for you later on, trying to sleep or just being calm in general. So any of those can lead to medication errors, which medication errors, if you work in healthcare and you make a medication error, it can be a major thing. Definitely if you're even managing your own medications and you make one of those errors, it can potentially lead to some problems for you. The next topic is multiple concussions. And this one has a couple different ways that we can look at it as well. If you have a second concussion that occurs or second head injury that occurs while you're still recovering from the first one, there is a chance that you can experience something called second impact syndrome. This usually happens within the first few days. So if you have an injury and then within days you have another one, some of the research identifies the first 10 to 15 days as kind of being the highest impact rating there. So if you have another injury within the first 2 weeks after you have a head injury, it can lead to this thing called second impact syndrome. And second impact syndrome can be life-threatening. It's very rare, but it can be life-threatening when it happens. And even if that second injury is mild, it doesn't even have to be a major type of thing. Some patients will get whiplash. They don't even hit their head. They don't have loss of consciousness. It doesn't seem significant, but that second injury can lead to swelling of the brain that can lead to death. Most often we see this with high impact sports. So this is why so many different rules have been put in place for return to play after an injury. If somebody has a head injury while playing a sport like football or hockey, if they're deemed to have a concussion, they need to be out until their symptoms resolve. Because if they're not resolved yet and they return to play and they have that second impact, that can lead to this second impact syndrome. When we look at trying to identify it, diagnosing this can be challenging because the symptoms overlap each other. You had those first concussion symptoms, now you have more concussion symptoms. So it can be really challenging to try to identify it. You can get head CT again to see if there's a head bleed, but again, in the absence of a head bleed, you may or may not see the swelling on the brain. It doesn't always show up on the imaging. So it's challenging, and you have to watch somebody very carefully if they do have a second concussion while they're recovering from that first one, again, especially in those first few weeks. According to the research statistics, when we're looking at the mortality, the disability related to it, at least 50%, at least half of all the people that have second impact syndrome will not survive it. One of the research studies said somewhere between 50 and 100%. So at least a half of all of those people will not survive. And 100%, it's documented that 100% will have some sort of permanent impairment. So that's a pretty staggering response for this thing that we used to think of as a pretty simple thing. But again, this is why all the rules are in place for those high impact sports, whether it be college level, even in high school and younger for some of these when we're looking at the Heads Up CDC protocol, and then the professional sports. They do take it very seriously. They need to take it very seriously. So when you see your favorite athlete taken off the field, don't think of it as being a detriment to the team. Think of it as being a very important thing to help that person heal so that they can get back onto the team and that they don't have anything life-threatening happen to them. When we have multiple concussions, we're not all going to end up with second impact syndrome. We're not all going to have that because it is a rare finding. It's severe enough to talk about, but it is a rare finding. However, multiple concussions can lead to the increased risk for chronic traumatic encephalopathy, CTE, the thing that's getting all sorts of attention in the news related to sports. We did discuss this back in letter C, so you can go back and talk about that or listen to that conversation there. But it is a significant finding that leads to personality changes, memory changes. Its degeneration of the brain can be like a dementia type of presentation as well. I have had several patients come into my office concerned because they've had multiple head injuries, wondering if they might be at risk for CTE. And unfortunately, this is not something that we can diagnose while somebody is alive. It's just like Alzheimer's. We can only confirm it on postmortem autopsy, but there are things that we can look for, such as those personality changes, the dementia types of things. It's going to be a supportive diagnosis more than anything. So we can suspect it and we can try to treat it. There's a lot of research coming out now to look at all aspects of this. So there will be more to come in the future on this CTE conversation, but it does put you at increased risk once you've had multiple head injuries. And then with each subsequent concussion, with each subsequent brain injury, that potential of getting back to your original baseline goes down and down. So you might set a new baseline after your new injuries because there are some permanent deficits that will remain once you've had multiple concussions. It's just gets more and more difficult to get back to that original baseline. It also takes longer to recover. So with each subsequent concussion, sometimes it takes less impact to cause another concussion. So you might hit your head on the corner of a cabinet in the kitchen, and most people can walk by and do that and never have any issues. But if you've had multiple head injuries and now you hit your head on the corner of that cabinet, now you have more concussion symptoms again. Now you need to get back into physical therapy and work on your balance again because things are thrown off yet again. So it becomes easier to get more concussions and it takes longer to recover from them. We also have an increased risk for mental health conditions with somebody that has multiple head injuries as well. So all of these things to say that it's really, really important to try to protect your head. My friends have joked with me that I need to get bubble wrap because I have had multiple head injuries in my life. And yes, I had another one not so long ago, unfortunately. And I'm now back working with some of my therapies to try to improve myself again because, yes, it does happen. And it's pretty easy to have happen, unfortunately. So lots of things to consider when you've had multiple head injuries. The next word that I have two more for you today. The next one is the military. And when we're talking about military, there are a couple different things to consider with this as well. If you have a history of head injury, it can potentially disqualify you from even joining the military. That's not to say that you should lie on your application because of all of the risks we just talked about with multiple head injuries and things like that. So if it was a very mild one, you didn't have any long-standing effects from it, likely won't disqualify you. But if you had a significant one, there's a chance that could disqualify you from the military. You can try to argue that disqualification and try to get reinstated. And that does happen in some cases as well, but just wanted to kind of put that out there that can be a thing. That said, concussions, head injuries are common in the military. Again, probably some branches might have more increased risk than others, depending on your physical injury capacity there or potentially what role that you play in the military. Not play. It's probably not a great word for that, but role that you hold in the military. Blast injuries in general are most often what we hear about with military concussions. You can have concussions, head injuries from normal things. If you're in the military, you're playing sports with that. Yes, you can still have a sports-related concussion. You can still get in a car accident. You can still have the normal kinds of concussions, but blast injuries are something that is a little bit more unique to military. Police officers can see some of this as well, but just being near the shockwave. You don't have to hold those high-powered weapons. Just being near them sometimes can cause it. And then explosions that might happen near you as well. Those shockwaves can affect your deep, deep brain tissues that most head injuries where you hit your head don't typically cause the same kind of injury that you see with the shockwave. That shockwave can lead to widespread effects on the brain and is essentially like experiencing multiple concussions at the same time. So it's a different beast than we see with your typical run-of-the-mill concussion, for lack of better terms on that one. Some studies have linked closer proximity to a blast with increased severity injury. Some of them just talk about just multiple exposures to begin with. Potentially, depending on how close you were to the blast, it might be more similar to somebody that was farther away and had multiple injuries. Regardless, the best way to assess this, there is a assessment questionnaire. The MACE-2 is the concussion evaluation. It's a tool. It is not the end-all be-all of diagnosis, but it is a tool similar to the SCAT-5, the other ones that we have for different sports and things like that, when we try to identify if somebody has a concussion. It first off looks for the red flags. It asks about a head hit or even acceleration or deceleration of the head, which I love that's actually on there because not all evaluation tools have that. It assesses for any kind of alteration of consciousness or loss of consciousness. So it can be that confusion, that bell rung type of sensation, or loss of consciousness, where many scales just look at loss of consciousness. Also looks at amnesia, your symptoms, takes into account history of head injury in the last 12 months, history of migraine headaches, other types of headaches, a history of depression, anxiety, similar to other scales. And then if it's positive so far for those things, then you continue. You assess orientation, memory, speech, strength testing, gait testing, looking at the eyes, and cognitive testing such as looking at concentration, delayed recall, and then the VOMS exam, that vestibular ocular motor sensitivity exam when we're looking at the eye movements, looking for vestibular issues. And then if it's positive, it triggers a progressive return to activity protocol similar to like the return to sports protocol that we have for athletes. And just kind of interestingly on this one, the DoD, Department of Defense, has worked with several civilian groups to do a lot of research on different tools that can be used to identify concussion, try to treat it, kind of reduce risk where it can. Back in 2021, there was a research article published about the BrainScope 1. Dr. Scheller and I talked about this earlier this year. They utilized BrainScope because it started with the military out on the coast there too. So they had that military experience brought to civilian use. BrainScope 1 is a handheld EEG device that can really identify if you have a risk for a possible head bleed. So it helped to identify if military personnel needed to be immediately evacuated, if they needed to be airlifted away from the location that they were and get further imaging and testing and treatment based on the potential for that brain bleed. The point of this was to try to excessive medical evacuations. And that initial study was funded both by the DoD and the NFL. So using this on the sidelines of the games, using this in military, trying to see, does somebody need to be immediately taken out because they need a head image done to look for a brain bleed? And it's pretty remarkable to see that we can look at this kind of testing and really determine if that is necessary. I did see something about this on LinkedIn earlier this year too, but it kind of relates back to the other part that I have here. In 2024, last year, FDA and the Army announced that they had FDA clearance for Abbott's iStat testing, which looks at the biomarkers for brain injury. And that biomarker for brain injury, it kind of peaks within those first 12 hours after the injury, maxes out, I think, around that 24-hour mark. That can also help to determine if somebody needs head imaging, if they're high risk of having a brain bleed. So both of these things, whether we're doing that handheld EEG or doing the blood testing biomarker, looking for that potential for increasing the biomarkers or the brainwave activity that shows us that they're at increased risk of head bleed, we're then streamlining that process for evaluation. And it's really cool how we can start this all up in our military personnel, bring it back to civilian use, and we both benefit from it. So it'll be fascinating to watch how these next two things really get used more. We don't hear a lot about either one of these things, but it is out there. I also was contacted by a Finnish company who was also trying to create something like Abbott's iStat as well, looking for biomarkers. So that's definitely going to be up and coming in ways that we can try to evaluate this and get further treatment on it. I think in general, there's not a lot of attention put on TBI related to military personnel. A lot of it is kind of kicked back to PTSD. But we have had that conversation before on this show about the fact that if you have PTSD and a TBI, it will complicate your recovery. So a lot of people coming back from military experience, from being in the battlefield, being in some sort of military fight, even if it's just going to basic training, there's some PTSD involved in all of that. So PTSD, yes. But if you also fell or had an injury or had a blast explosion, you now have a TBI that you're dealing with as well. So there's still room to grow on all of that. I think we have potential areas that we can improve for our veterans. But it's a very cool kind of start to the conversation, at least. And then my last word for you today is menopause. So specifically for my females that are listening and or their family members, caregivers, providers, there's a lot of overlapping symptoms with menopause and TBI, including memory issues, sleep problems, mood changes, some of those we just talked about today. And then menopause can increase the risk and severity of concussion due to declining muscle and bone mass and hormone shifts that can put us at necessarily an increased risk of obtaining a brain injury because we can fall. We can end up with injuries because of that declining muscle mass. However, concussion can also lead to earlier onset of perimenopause and menopause because of hormonal imbalances from the pituitary gland being affected during the injury. So they can affect each other. There's definitely a vice versa relationship on this, both affecting each other. And the co-occurrence of a TBI and menopause, perimenopause, if a woman is of that age category, which perimenopause can start anywhere between the ages of 35 to 50, that's a huge range. And then menopause typically starts around that age 50, but again, can go beyond that as well. So there's a lot of years that we have this potential co-occurrence with somebody getting a brain injury while they are going through perimenopause and menopause. And that co-occurrence makes management tricky. There is a lack of research, but in general, there's a lack of research on concussion and head injury in women to begin with. Most of the research has been done on men, so clearly there's probably going to be a lack of research on menopause and TBI as well. That said, there was an article published in 2024 in the journal Women in Health, and it was describing the development and the testing of a new scale for menopause symptoms after brain injury. So starting the whole conversation about the fact that we need to do more for women of this age that potentially might have a brain injury. So addressing the fact that our hormones get affected by TBI and that TBI can be affected by our hormones being affected. So just starting that conversation, we're in the baby phases of that. There's much more to come. Hopefully this will lead to much more research in this area so that we can really work to identify the problem areas, identify management, try to come up with better management techniques for women who are in that perimenopause phase and experiencing a traumatic brain injury. Management of this that we have currently. See a specialist. Get the hormone levels assessed after a brain injury. And hormone replacement therapy, HRT, kind of got a bad rap years ago from the study that said that HRT put you at higher risk for breast cancer. However, most of the hormones that were used in that study were synthetic, and many of them aren't even used anymore because they were identified to be at higher risk. They also researched people who were 70 and older, which they're going to be at higher risk for breast cancer to begin with, and now you're giving them hormones. That's just not a good idea. We typically don't start therapies, hormone therapies at that age anymore either. So the newer forms of the hormone replacement therapies are bioidentical. They're not the synthetic ones anymore. They're safer. They actually have benefit. There is a lot of research with this on progesterone as well. So progesterone replacement can be really helpful, not progestin, but progesterone replacement can be helpful for brain healing because of that lack of progesterone that can cause more mental issues. So trying to kind of find the best of both worlds here on this one. Get the treatments that are necessary that will help with the symptoms, help with mitigating both concussion and menopause symptoms for these patients. Psychological treatment, CBT, behavioral therapy, cognitive behavioral therapy can be very helpful for the psychological impact of this because mental health comes along with a lot of those hormones being out of whack. And then a healthy lifestyle, as we've talked about before. So good sleep, eating enough, drinking enough water, all the things that we should be doing that many of us aren't doing most of the time. Those things can help manage some of these hormonal symptoms as well. But again, just starting the conversation to realize that it is an issue that we need to talk about. My patients are always surprised when I ask them about their hormonal balance issues. Where are you with menopause? Are you still having menstrual cycles? Have you noticed a change in your menstrual cycles? Because again, menstrual cycles in general can be affected. There was a study in young female athletes that found that like 78% of the young female athletes had changes in their menstrual cycles after a brain injury. So any of that can be affected, and we're not always putting those two things together. So our brain affects every part of our body. It would make sense that just about anything can be affected from that. That is my letter for you for today. All the topics that we can cover related to brain injury, related to the letter M. Really interesting conversation on all of these topics. And once again, if you have suggestions for other words that I should cover from and moving forward, any of these conversation topics, let me know if you have suggestions and I will be glad to work them in. Otherwise, again, maybe you found something helpful in there that helped you or a colleague or a loved one, a caregiver. Whatever the case may be, hopefully you found something helpful in the conversation today. And I hope you will join me again next time for the next installment of the ABCs of Concussion. Until then, have a good day. Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, and share this with others to help me continue on with my mission to help people live healthier, happier lives. Go to www.brainwellnesssolutions.com to see what I'm up to and get links to all the social medias there. See you next time.